Hi, my name is Shikha. Today I'm going to present a case study of a patient who has diabetes ketoacidosis. I'm working right now as in acute medical ward, and this patient is admitted from ED, and I got my handover. Now I'm admitting the patient. This patient is Mr. MB. He is 76 years old man. He has delirium, dehydration, and blood sugar management. Recent chest infection on antibiotics and steroids. He has nausea and vomiting with poor oral intake. He is confused pre-admission and self-administering insulin without eating. He is admitted for IV fluids, IV antibiotics, and DKA management. His background is he is 76-year elderly Italian man who is from non-English speaking background. In home, he lives with his elderly wife and he has comorbidities. He has poor English language skill, minimal social supports, and he's also a carer for his wife. He has declined vision, hearing, and mobility. He is struggling to manage at home. His past medical history is type 2 diabetes, and he's been for insulin for 30 years. He has hypertension, hyperlipidemia, COPD, and chronic kidney disease, ischemic heart disease, atrial fibrillation, and on coagulation, anticoagulation right now. He has osteoarthritis and he has joint and back pain. In his medication profile, he is on insulin, novorapid, metformin, aspirin, rosuvastatin, sedatyde and Cipriva inhalers, warfarin, Targin, and Ventolins, and Getinispe, PRN. Reason I choose this presentation is because it's common presentation and a complex presentation with multiple comorbidities, multiple factors affecting his presentation, and scope to discuss examination and management relevant to case and discharge and social implications. First of all, in his case, I would like to do initial observation, which is I will follow by Dr. ABCDs, where in this scenario, D is dangerous, there is not danger, and response is he's responding to voice, GCS is 13, and eyes opening at 3, verbal is 4, and motor is 5. And for S, sent for help, made call because he has high blood sugar level. And for A, his airways is patent and clear. Breathing is deep, labored, using accessory muscles. He has Kussmaul breathing with fruity odor. Circulation is pale, cool peripheries. Capillary refill time is 5 seconds because it's related to dehydration, DKA, and polyuria. And his skin looks dry. And I would like to do vital signs because it's very important. So I'm gonna attach to cardiac monitoring, pulse oximetry for the saturation monitoring. Heart rate is 115 minutes and it's irregular because AF uncontrolled from DKA, infection and dehydration, also low pH. His blood pressure is 98/64 from above, causing confusion from cerebral hypoperfusion and poor peripheral circulation. Respiration is 32 minutes and it's labored. Saturation is 96% on 2-liter oxygen by nasal prongs. His temperature is 35.8 centigrade, and blood sugar is high. Ketone is 4 mmol per liter because of high fat metabolism. His CNS, ABPU, verbal and confused response, pupil normal size and reacting to light, motor by moving arms, he can move arms and legs against the gravity. It's 4 and is equal in all limbs, no sign of stroke. CVS, no JVP, fast dual heart sounds, dry skin, bilateral wheeze, and coarse crepitation in respiration sound, abdomen, epigastric tenderness, vomiting, gastritis from stress, and abdomen is soft to touch. Evidence-based nursing care management, I would like to do that approach. And the management of high blood sugar comes first, bringing to normal in 24 hours, ensure fluid and electrolyte imbalance corrected, maintain acid-base balance, treat underlying cause, prevent complications, patient education and discharge plan, positioning, head up so patient can breathe properly, and to prevent aspiration. And this patient should be kept kneel by mouth to prevent vomiting, antiemetics, side positioning, and suction to maintain airway. Regular vitals in 15 minutes initial hours and then later hourly. Monitor GCS, blood glucose level, and ketones hourly. Monitoring blood gases for pH. Strict fluid diet he should keep in, and ECG for arrhythmia and AF, electrolyte imbalance, hypokalemia, and acidosis can affect. In IV fluids, ideally normal saline as ordered with strict balance chart to prevent hypovolemia, compensate for acidosis. Insulin infusion recommended 0.1 units per kg per hour to prevent fat metabolism and reduce ketone production and use glucose. Potassium replacement to maintain 4 to 5. Hypokalemia from intracellular shift. In this case, it can affect, so it's very important to balance a correct potassium replacement. Complications prevent hypoglycemia as insulin is infusion and prevent fluid overload, cerebral edema from acidosis and rapid correction of hyponatremia, pressure area, patient education of diabetes management, refer to social worker for community support, diabetic educator, vision test and impairment strategies. Thank you.